Good morning, team. Let's talk about something thrilling, APG billing. I know, try to contain your excitement. Think of it as a system, yes, another system in healthcare, because apparently we don't have enough of those. But this one tries to make sense of how outpatient services get paid. Outpatient, when you go to the hospital or clinic, get something done, and get to leave the same day. And unlike that one time you tried to assemble IKEA furniture and felt like you'd never escape, this is theoretically more straightforward. Now, why do we even need these APGs? Well, imagine the old way. It could be a bit like a Wild West saloon brawl of billing codes. Every little thing billed separately, leading to massive, confusing bills that make your phone contract look like a children's picture book. APGs are meant to bundle these services, so instead of paying for the cotton swab, the tiny bandage, and the doctor's 5 seconds of wisdom separately for a small procedure, APGs group them together. The goal is to create a more predictable and standardized payment system. It's about bringing some order to the chaos, a bit like a very, very patient librarian in a room full of screaming toddlers. The basic idea is this: similar outpatient services should have similar payments. Groundbreaking. I know, this isn't about your charming personality getting you a discount, sadly. APGs are focused on the clinical aspects of your visit and the resources used. It's an attempt to link payment to the actual work and stuff involved, rather than say how nicely the doctor asks about your weekend before telling you the not-so-great news about your brain tumor. So APGs are essentially a classification system to address the cost incurred by facilities for outpatient care. They take the thousands of possible outpatient services and sort them into a manageable number of groups. Each group represents a set of services that are clinically similar and require a similar amount of resources. Think of it like sorting your laundry, if your laundry involved things like minor skin lesion removal and intermediate eye examination. The system is designed for all sorts of outpatient settings: hospital outpatient departments, ambulatory surgery centers, and even clinic services. So, how does this magical APG sorting hat actually work? Well, it looks at a few key things. First, procedures. This is a big one. If you're having something done to you, whether it's a colonoscopy, joy of joys, or getting a tiny camera shoved up your nose, even more fun, that procedure is a primary driver for APG assignment. The system is smart enough, or at least programmed enough, to know that a complex surgical procedure isn't the same as someone looking in your ear with a light. It tries to group procedures that are similar in terms of clinical complexity and the resources they use. Then there are evaluation and management, or E&M services. This is a fancy term for your basic doctor visit. When you sit there, describe your alarming new symptom, and the doctor nods thoughtfully before, hopefully, figuring out what's wrong. These visits are also classified by APGs based on things like the complexity of the medical decision-making involved. A quick checkup for a renewal of your toenail fungus cream prescription is different from a detailed consultation for a mysterious multi-symptom ailment that has you consulting Dr. Google at 3 a.m. The APG system tries to reflect that difference in payment. Ancillary supporting services also get bundled in. Think lab tests or X-rays ordered to assist in the patient's diagnosis or treatment. If you go in for a significant procedure, the APG for that procedure will often include the payment for common ancillary services that go along with it. It's like buying a combo meal. The fries and drink are included with the burger. You don't pay for each grain of salt on the fries separately. This bundling is key to simplifying the billing process and making costs more predictable. No more surprise bills for air breathed in waiting room, hopefully. The classification isn't just random, of course. It's based on a detailed logic that considers the patient's diagnosis, the procedures performed, and even patient characteristics like age or sex if they significantly impact resource use. The system uses standardized coding like ICD-10 for diagnoses and CPT-HCPCS for procedures to understand what happened during your visit. It's all very data-driven, which is either reassuring or slightly terrifying, depending on your general feelings about algorithms running the world. But the goal is to ensure that services requiring more work, more skill, and more expensive gadgets get grouped into higher-paying APGs. Okay, so we've sorted the services into these APG boxes. How does that turn into actual money? This is where crucial concepts come into play. Base times weight plus capital. This information can be found on the NYS Department of Health website. It sounds a bit like a bizarre boxing match, but it's how the system determines the payment for each APG. Each APG is assigned a relative weight. This weight reflects the average amount of resources. Think staff time, supplies, equipment used for services in that particular group compared to other APGs. A higher weight means more resources and thus a potentially higher payment. It's like saying a complex heart procedure APG has a much heavier weight than a simple blood draw APG. The base rate, on the other hand, is a monetary amount. It's a conversion factor, essentially. This base rate is multiplied by the APG's relative weight to calculate the actual payment for that APG. Think of it this way: the weight tells you how much more or less resource-intensive one APG is compared to another, and the base rate puts a dollar figure on that. This base rate can vary. It can be specific to a hospital, a region, or a particular payer. Factors like local wage levels or a hospital's specific cost structure can influence it. So the same APG weight might result in different payments in different places because of different base rates. Let's imagine an example. Say APG 123 is for intermediate ear examination and minor procedure, and it has a relative weight of 1.5, and let's say the payer's base rate is $100. The payment for this APG would be 1.5 weight multiplied by $100 base rate, which equals $150. Now, if APG 456 is for complex outpatient surgical procedure with a weight of 10.0 using the same $100 base rate, the payment would be $1,000. It's a system designed to scale payment according to the intensity of the service provided. Simple, right? Well, simple in theory. The actual calculations and adjustments can get devilishly complex, but that's the core idea. There are also different types of APGs that influence billing. For instance, there are significant procedure APGs, which, as the name suggests, cover major procedures. Then there are medical APGs, which typically cover those E&M visits we talked about, the doctor visits. You might also see ancillary APGs if certain ancillary services are provided on their own, not bundled with a major procedure. Sometimes a single patient visit can result in multiple APGs being billed, especially if distinct, unrelated services are provided. For example, you might have a significant procedure and then a completely separate diagnostic test for a different issue on the same day. It's not always a one-to-one relationship. So after all that, you might be wondering, why go through all this trouble? Is this APG thing actually any good? And the answer, like with most things in healthcare, is, well, it's complicated, but it has its points. One of the main claimed benefits is streamlining healthcare costs. By bundling services into predictable payment groups, APGs can help control the financial hemorrhaging that sometimes happens with fee-for-service models, where every single item and service is billed separately, potentially encouraging more services than are strictly necessary. With APGs, providers get a set amount for a group of services, which can incentivize efficiency. This leads to another big plus: improved efficiency. If a hospital or clinic knows it's going to get a fixed payment for a particular type of outpatient encounter, it has a reason to provide that care in the most cost-effective way possible without, and this is crucial, compromising quality. This means looking for ways to reduce waste, optimize staffing, and generally run a tighter ship. It's like giving everyone a budget for their part of a group project. Suddenly, people are much more careful about how many gold-plated paper clips they use. This can lead to better resource management, which in an ideal world benefits everyone. Furthermore, APGs can offer greater transparency and predictability in payments for both providers and payers. Providers have a clearer idea of what they'll be paid for certain services, making financial planning a bit less like reading tea leaves. Payers like insurance companies or government health programs can better forecast their expenditures. This predictability is a big deal in a sector as vast and financially chunky as healthcare. It allows for better budgeting and potentially more stable health insurance premiums. Though let's be honest, stable premiums often feels like spotting a unicorn riding a Loch Ness monster. Of course, no system is perfect. APGs have their own complexities, and there are always debates about whether the weights are right or if the groupings truly reflect clinical reality. There's also the risk of upcoding, where providers might try to classify a service into a higher-paying APG. But in principle, the APG system is an attempt to bring a more rational, resource-based approach to paying for the ever-expanding world of outpatient care. It's about managing costs, encouraging efficiency, and trying to make sure that when you go in for that outpatient procedure, the financial side of things is at least a little less painful than the procedure itself. And in healthcare, we'll take any reduction in pain we can get.